Good morning, everyone, and welcome to Within's continuing education training. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to my colleague, Malika Brown-Crosby, presenting on the topic of culturally sensitive care for patients with eating disorders. Malika is a graduate of Hunter College with a master's degree in mental health counseling and has over 10 years of experience working with various populations in the field. She currently works as one of our senior therapists here at Within, and she also co-facilitates our BIPOC group, our Black Indigenous People of Color. We're so happy to have her here. Malika provides care for clients with eating disorders and is passionate about helping clients uncover what is at the center of their eating disorders and supporting them to heal their relationship with food and their bodies. Malika also specializes in working with clients with race-based traumatic stress and substance abuse. Before we start the CEU, I have some general information to go over in regards to the credits. Evaluations will be sent to your email after registering for the presentation. Once the evaluation is complete, you will receive a link to download your CE certificate. Please utilize your CE Go dashboard for all things CE related. The presentation will also be available in a recording within 24 hours. You will not get credit for watching the video. The credit will only be given to those who attend live with us. To access the video, please use your CE Go dashboard. If there are any technological issues and you need to change devices during the presentation, you will still receive credit. If there's any additional questions or concerns regarding obtaining credit, if there's a potential tech issue, I'll provide my email in the chat as well as CE Go support. And other than that, I will pass things over to Malika, and we are so excited to have you presenting with us today.
Thank you so much, Ashley. And thank you everyone for taking time out of your busy schedules to join us today for this presentation and providing culturally sensitive care for patients with eating disorders. I will be looking this way. I have a second screen. So just know that I am fully with you and I'm present. All right, well, let's dive in. Okay. So the goals of this presentation today are to discuss some of the considerations for providers working with marginalized groups, providing treatment for eating disorders. We want to explore the importance of cultural sensitivity practices for the eating disorder population. And we hope to be able to enhance our understanding and practices of providing culturally sensitive care for patients with eating disorders. Participants today will be able to define cultural competency, cultural humility, implicit bias, and marginalization, examine their implicit biases and reflect on how they may impact the care of patients with eating disorders, the care that eating disorder patients receive, identify groups that typically feel marginalized in eating disorder treatment environments, and identify at least 5 strategies for making eating disorder treatment more inclusive by using culturally sensitive practices. So we have a visual here that we are starting with, just wanting to show some diversity when we look at these images, which helps to reflect the reality that anyone can struggle with an eating disorder, anyone can be impacted by an eating disorder. And we know that several research and clinical reports have identified that eating disorder symptoms are beginning earlier in both males and females. Some research also suggests that most ethnic and minority clients report experiencing at least one microaggression from their clinicians or while in a treatment setting. Clients with marginalized identities may be particularly vulnerable to the power imbalances that might exist, which can oftentimes threaten the therapeutic process and even threaten that therapeutic alliance. So what is cultural competency? Cultural competency is the ability of systems to provide care to patients with diverse values, beliefs, and behaviors. including tailoring delivery to meet patients' social, cultural, and linguistic needs. So we want to be able to meet our clients where they are and to continue to be mindful of that in our practices. So cultural competency emerged as a framework for addressing diversity and inequality in the US around the 1980s. The main idea was to try to address and to reduce the ethnic, the cultural, and the racial disparities in access to care and to improve outcomes. So what the research was showing is that essentially specific ethnocultural and racialized groups suffered health disparities and social disadvantages as a result of the meanings and material consequences of their socially constructed identities. So essentially, they recognized that marginalized groups were suffering inequalities in health, specifically because of their identities. Cultural competency has evolved from simply just gathering information and making assumptions about patients on the basis of their sociocultural background to the development of skills to implement the principles of patient-centered care. Cultural competency, however, is more than just gathering a discrete set of skills or knowledge. And it really requires us as practitioners and treatment centers to engage in ongoing self-evaluation of our practices, including our limitations. We want to also be mindful and look at our policies and to continuously ask ourselves if we are in fact providing patient-centered care. So let's talk about cultural humility. There has been a lot of emphasis on shifting the language from cultural competency to cultural humility. And although in some cases we may use those terms very interchangeably, they're not the same. So cultural competency, in some ways, it might imply that we know all the things about all cultures and make assumptions that our practices might already be in line with and taking people's cultural experiences into account. Whereas when we look at cultural humility, at the core, it means that we are always reflecting, we're always learning from our patients, we're growing, and we're always adapting. Cultural humility acknowledges our blind spots, and we know as clinicians that we do often have blind spots. So cultural humility, it refers to the orientation towards caring for one's patients that is based on self-reflexivity, an assessment, appreciation of patients' expertise, on the social and cultural context of their lives, openness to establishing power-balanced relationships with patients, and a lifelong dedication to learning. Cultural humility also means that we have to admit that one does not know and is willing to learn from patients about their experiences while being aware of one's own embeddedness in culture. It is a process of self-reflection, discovery, in order to build honest and trustworthy relationships with our clients. Cultural humility, it also normalizes the process again of not knowing. And this is a key part of our self-awareness, which is absolutely necessary and crucial for our growth. As professionals, we share cultural blind spots that in many cases may underline assumptions of how we conduct therapy, how we may engage in supervision, and how we may just overall engage in our interactions with our clients and our patients. So all of these points are really just reiterating that our patients are the experts in their lives, and we want to be mindful of that and continue the process of reflective practices and continuous learning from our patients and ongoing training. So here we're going to look at the multicultural social justice and counseling competencies. So this is one of the frameworks that is utilized to look at cultural humility, cultural competence. How are we showing up with our clients? What are some of the considerations and things that we want to be mindful of? So, so this framework, it illustrates the major concepts related to developing multicultural and social justice competence. At the core is the belief that multiculturalism and social justice can be at the center of all treatment. It really aims to reflect that fluidity of the identities and how the dynamics of power, privilege, and oppression can impact the therapeutic and treatment relationship. So the interactions are categorized into these 4 quadrants. As you can see, we have, timing out. So as you can see, we have at the top left corner, we have the privileged counselor and the privileged client. At the top right corner, we have the privileged counselor and the privileged client. At the bottom left quadrant, we have the marginalized counselor and the marginalized client. And at the 4th quadrant, the bottom right quadrant, we have the marginalized counselor and we have the marginalized client. So the client and the practitioner's interactions may fit into any one or in any numerous ways in each of these quadrants. And the practitioner's self-awareness, the client's worldview, the counseling relationship, and counseling advocacy interventions. So if we have a client, for example, who, let's say we have a gay male counselor of color who is working with a heterosexual female client of color, they may experience these interactions through various lenses. So they both may perceive their interaction to stem from the 4th quadrant, for example, because they may share, because of their shared racial identities and a common experience with respect to issues of racism, microaggressions, if they've ever experienced any of those things directly or indirectly. Alternatively, if we look at the client from the top left corner, that client may consider their interaction from that perspective to be because of their different identities. So the client may feel, in some ways, the client may feel displaced or disadvantaged because of the counselor's privilege and of being a male counselor. And if we look at that from the 3rd quadrant, there may be a difference with respect to their sexual orientation that could present another scenario where the counselor may be placed at a disadvantage. So it really just kind of depends on the individual circumstances and the experiences that they're bringing into the room and into that relationship. So just a little bit more on those quadrants. So the quadrants reflects, again, that complex identities underprivileged and marginalized statuses that practitioners and clients may bring to the professional relationship. Clients and practitioners are both members of various racial, ethnic, gender, sexual orientation, economic, disability, and religious groups. These identities are categorized into privileged and marginalized statuses. A client or clinician may hold either status or both statuses simultaneously. And these statuses are prevalent depending on how each individual is experiencing the current situation. So let's talk a little bit about implicit bias. So what is implicit bias? Implicit bias is a form of bias that we know occurs automatically and unintentionally, that nevertheless affects the judgments, decisions, and our behaviors. Implicit bias is an unconscious association, belief, or attitude towards any social group. Due to implicit biases, people may often attribute certain qualities or characteristics to all members of a particular group. And this can lead to stereotyping, stigmatizing, and marginalization. So how can we assess our implicit bias? So Project Implicit offers 15 association tests. Anyone 18 years and older can take any one of those tests that they offer on different topics on implicit bias. So towards the end of this presentation, I will have a resource link, and a link would be provided there. A link would be provided there for anyone who might be interested. I'm sorry, I don't know why I'm going off. So a link might be provided for anyone who might be interested, who's never taken any of these before, and I highly recommend it. And a lot of the assessments are fairly short. They can take about 10 minutes or so to complete. And also, optionally, you can choose to have your results used for research purposes. So implicit bias can impact the recognition of eating disorder and lead to, I am so sorry, I have no idea why I'm timing out. I am not going to touch my screen. Okay, so implicit bias can impact the recognition of eating disorders and sometimes and oftentimes can lead to delayed diagnosis. Implicit bias can impact the care of our patients with eating disorders. And some of the ways we may see that happening is with weight stigma, also making assumptions about diagnoses based on someone's body size. We may have some non-diverse therapeutic groups and group topics, making assumptions that all clients with the same eating disorders or eating disorder diagnoses may be struggling with the same body image concerns. And we may also see an unwillingness sometimes to learn from our clients. And we might be experts in eating disorders, but we know that our clients or patients, they are the experts in their lives. So again, because of our own blind spots, there may be some biases that we may see showing up. So marginalization occurs when a person or groups of people are less able to do things or to access basic services or opportunities. So some examples of marginalized groups, we may see that in showing up with size, we may see that with gender, race, age, and socioeconomic status. In many instances, eating disorder professionals sometimes may not feel equipped to care for patients from marginalized backgrounds. So we must have a commitment to ensure that we are engaging in thorough and critical self-reflection. So I have a question that I'd love to pose, and I give you all a couple minutes just to put some answers in the chat. So the question is, what are some types of marginalization that you think might happen or can happen or you've known to have happened in eating disorder treatment? If you will take just a couple minutes and put a couple of your responses in the chat. And Ashley, if you're able to read those for me, that would be so kind. So that question again is, what are some of the examples of marginalization in eating disorder treatment? This could be things that you're thinking might happen. This could be things that you know have happened.
Malika, you have several comments here in the chat. I'll just read a few to you. It says here there are lack of access to food, weight, gender, lack of knowledge or response to cultural food practices, assuming it is predominantly a white disease, body size, downplaying medical complications of restriction in individuals who are not underweight, locations, a food desert, culturally, what can and cannot eat, gender, genetics, shaming cultural foods as unhealthy, misdiagnosis and lapses in care of African-American female/non-binary identifying clients, more stigmas and stereotypes. EDs are a white female disease. Clients of different cultures, feelings as if they need to change their behaviors to fit into group norms. I mean, there are several here. Do you want more?
No, those are wonderful. Thank you all so much. Yes, absolutely. Yes. So we know that clients oftentimes they do experience a lot of what you all put in the chat. Absolutely. And the list goes on. The list goes on for sure. Lack of limited financial resources. Another thing too, from when we're thinking about from a marketing perspective, sometimes we miss that in our advertising. Sometimes we miss our BIPOC community. Sometimes we miss our LGBTQIA+ community. And, financial resources is oftentimes a huge one that comes up as well. Yeah, so thank you all so much for that. All right, so we want to take a quick look at moving from exclusion to inclusion. So we have some illustrations here, right? We can take a look at what exclusion looks like, what segregation looks like, integration, and then the ultimate goal is, of course, inclusion. So in the case of segregation and my goodness, in the case of segregation and integration, some space or spaces, some attempt to include is often perceived as that is happening. But at the root of that, there's still a lot of exclusion. You're not fully a part of. We will let you in with these limitations. We will let you in, and you can only occupy these spaces, and there may not be access in a lot of ways. So the goal is inclusion, and it is important for treatment centers to examine where we are in this process. Some of us might be working towards inclusion and not fully there. And, again, going back to, I think when we think about our patients, how crucial cost of treatment is. And that is unfortunately a huge determinant for marginalization and exclusion from eating disorder treatment. So if we're thinking about that framework of being othered, right, and how that, how marginalization shows up, we know that marginalization can lead to poor self-esteem in a lot of instances, and poor self-esteem can lead to vulnerability to eating disorder development. So let's take a look at some of the research. The literature on cultural sensitivity treatments for clients with eating disorders in the United States within diverse population is limited. It's gotten better, and it is getting better, but there's still a lot more for us to grow in that area of research. And there's often a misconception that eating disorders primarily affect white females from a specific socioeconomic background and do not occur in other ethnic and racial groups. So that was one of the things that you all mentioned. And of course, contrary to this misconception, it is well documented that eating disorders do affect all people from diverse and ethnic and racial backgrounds. Most treatment and assessment protocols have been developed primarily for whites and may not be valid for the use of other ethnic groups. And so this is something that we have to always be taking into consideration, right? We want to be able to look at the human before us. We do have to use our assessment tools, and we have to be able to take the full person sitting in front of us into the picture as well, right? And take those ethnic and their cultural and their racial experiences and take all of that into consideration as well. So functional impairments associated with a lifelong history of eating disorders is comparable or higher in diverse populations. So Latinos, Asian Americans, and African Americans as compared to non-Latino whites. In a large national representative comparative study in the United States, Marquis and colleagues found that in a sample of Latinos, Latino and Latinas, African Americans, Asian Americans, and whites, the prevalence of anorexia and binge eating disorders was similar across all 4 groups, right? So not that myth that is often, a lot of people still believe that it does only impact white females. In another study, in a population-based study of 2,793 adolescents, girls of Asian background reported the highest rate of disordered eating across all disordered eating behaviors when compared to their Black, Hispanic, and white counterparts. And other researchers suggest that despite higher average BMI than white or Asian American men, Black men reported higher body satisfaction, low prevalence of negative feelings about binge eating, and lower prevalence of being afraid of weight gain due to binge eating. So we may see higher body satisfaction in men, and we may also see increased increased disordered eating behaviors, but they may not seek professional help in instances like these, and a lot of the times often goes they go without being diagnosed because they're oftentimes not seeking out individuals. So in such cases, we want to be able to also consider the cultural experiences here in these instances. Other studies, racial discrimination was determined as a stressor for young Black women that could lead to maladaptive eating behaviors or disordered eating behaviors and eating disorders. 27 women in larger bodies participated in a 14-day study examining exposure to racial discrimination, eating behaviors, and racial identity. 81.5% of the participants endorsed exposure to racial discrimination, and those who reported racial discrimination had a higher level of overeating and loss of control. In another study, Black boys reported the second highest prevalence rates of unhealthy weight control behaviors and overeating, with 38.5% of Black boys endorsing unhealthy weight control behaviors and 10.1% reporting dieting. Rogers and colleagues found that the prevalence of dieting behaviors was amongst Black girls compared to their Asian, white, and Latino peers. Black girls endorsed the lowest prevalence of unhealthy weight control behaviors among the racial ethnic groups studied, though the prevalence of unhealthy weight control behaviors among Black girls was still considerable at 43.1%. Missing from recent research on eating disorders are the prevalence rates among racial and ethnic minorities, including Native Americans and individuals of two or more racial ethnic identities. So we're missing a lot of, there's a lot that we could continue to do as far as research in our BIPOC communities. And males represent 25% of individuals with anorexia nervosa, and they are often at higher risk of dying, in part because they are often diagnosed later, since many people assume males don't have eating disorders, which we know is very inaccurate. So research on providing culturally sensitive care for our patients with eating disorders. So a meta-analysis conducted that patient-therapist match does not always affect treatment outcomes. Becoming comfortable discussing race, ethnicity with clients may promote better treatment outcomes. And this could oftentimes be an uncomfortable topic or conversation to have and to bring up in the room. But research is really telling us that when we are able to do this, it's helpful, not only for our treatment outcomes, but also for building that therapeutic alliance. Suspending one's own preconceptions about race, ethnicity, recognizing individual differences, considering potential effects on the therapy, acknowledging the ways that power, privilege, and race might affect therapist and client work, being willing to take risks with clients, and staying open to learning. So several themes, as you all may be noticing, is continuing to come up, right? Being reflective, having that openness to learning, to continue to learn, to continue to grow. Also acknowledging important differences between the dialogues with client and within clinical supervision are critical to treatment success. And practitioners should admit their lack of knowledge, experiences, and ability to understand what it is like to be in the shoes of a client whose race or ethnicity differs from their own. So just really acknowledging those limitations is helpful. That self-disclosure is oftentimes, it could be necessary and being willing to say when you don't know, at the risk of the client possibly maybe having some concerns about that, or at the benefit of clients welcoming that honesty and that vulnerability, that can help to strengthen the therapeutic relationship and also to help to strengthen the treatment outcomes. This could also help in a lot of ways to neutralize that power dynamics and position of privilege sometimes on the practitioner's part, with being the expert in treating eating disorders, but again, reminding ourselves and just having some humility around the fact that we are not the experts in our clients' lives. So engaging in these conversations with clients, while potentially uncomfortable, it will and can provide some rich opportunities to put issues on the table, and is likely to be a great value in the therapeutic process. It is also okay for clinicians to acknowledge the sensitivity of this discussion, both in terms of his or her own discomfort and or in the context of the current political climate where race and ethnicity are particularly charged topics, right? So if you're treating clients and things are happening globally, locally, nationally, and you're working with someone from the BIPOC community, for example, you want to be able to check in with those clients and see what that might be bringing up for them. So culturally sensitive care for ED clients, the importance of providing culturally sensitive practices and being well informed about culture, race, ethnicity, national origin, and language is not only an ethical issue, but also essential for the effective implementation of services and research. Cultural adaptation requires a systematic modification of interventions to integrate clients' relevant cultural factors, so like their language, taking their values into consideration, religion, all of those things. So we may have various disciplines right now in the room. Some of us might be already providing direct care for patients in a clinic setting, in a treatment center setting, in private practice setting. Some of us may be in leadership roles and just overseeing the care of patients. And some of us might be conducting research or might be students at this time. So thinking about as a practitioner and leaders, we want to be able to stay up to date on the current research on providing culturally sensitive care for clients and patients with eating disorders. And as researchers, we have to be able to continue to examine the importance of providing culturally sensitive care for clients with eating disorders, because we're serving diverse populations, right? And as we've been talking a lot about today, anyone from any race, ethnicity, nationality, sexual orientation, gender identity, all of the things can struggle with an eating disorder. So approaching patients with marginalized experience will require validation, humility, openness, authentic connection, and comfort with discomfort. So again, reiterating a lot of what we've been talking about here today. What can we do as allies? We can reflect on events globally and the unyielding discrimination that affects members of minority communities. One example of this is our BIPOC group that we have at Within. We also have a special topic group at Within. So when things are coming up, it's happening locally, nationally, globally. We're very mindful that we're talking about these topics. We're creating spaces for these topics so that we could provide a space for support and a space for healing as well. Not acknowledge. So we want to acknowledge the inequalities and poor mental health. We want to show compassion. We want to believe them. So if someone says to you, I have experienced I've been marginalized in some way, I've been discriminated in some way, we want to believe them when they tell us their experiences. And we want to work towards a healthcare system that one that is trauma-informed, culturally responsive, and recognize the intersectionality of people's lives. So we want to just be mindful. We want to continue to be mindful and to also be intentional in how we're showing up. So we want to think about how we can help our marginalized patients move towards active empowerment and to embrace connection and belonging, because they are crucial tools in healing. So assisting patients in embracing pathways that evoke a sense of connection and belonging and help them move towards healing and eating disorder recovery and treatment are really, really important. So let's shift a little bit and talk about some strategies. So some strategies for making eating disorder treatment more inclusive for organizations. So we want to create an inclusive work culture. We want to hire diverse staff and create opportunities for promotion into leadership roles. We want to audit our policies and practices to ensure that they reflect the diverse backgrounds and perspectives. And so this should be an ongoing process. We don't build it and move on. We build it, we revise it, we look at it. We're always looking to make shifts and modifications as needed to ensure that we are providing the best care possible for our clients. We want to create a diversity and inclusion committee and invest in the implementation and recommendations for change coming out from that committee. Require leadership and staff to participate in ongoing training in cultural humility. So we want to continue to have that commitment to always learning and always growing and adapting as needed. We want to survey from the perspective of our patients and staff the cultural competency practices of the organization on an ongoing basis. So very important to have that ongoing feedback coming in. We want to look at our offerings, how accessible is our programs, right? The time of day, the days of the week. Are we only in person? Are we in virtual spaces as well, where we are going to be able to reach people who are not able to go to in-person setting for various reasons? We want to provide, providing weekend and after hours and virtual availability. We want to examine our fee structure and to provide affordable care to patients from marginalized groups. So we might want to think about scholarships, right? How can we give scholarships? How can we engage organizations out there that already have scholarships and see how we can help our clients get in touch with some of these organizations so that they will have the opportunity to be able to access the care that they deserve. We want to audit our marketing material ongoingly, and we want to ensure that for those of us operating in physical spaces, we want to ensure that the physical environment is accessible and suitable for our patients. So really leaning into creating a culture where everyone can feel like their voices can be heard and what they say matters. And again, if we're thinking about more like those brick and mortar type of facilities and treatment centers and private practices and all of the things, what does our setting look like? What does our waiting room look like, right? Being mindful of the magazines that we may have, the books, the artwork that we may have in our waiting room. We want to think about the location of geographically. Is it easy to get there? How feasible is it to get there? Is the building accessible for people with physical disabilities and limitations? And then we have some strategies for making eating disorder treatment more inclusive for our practitioners. So understand how your background affects your responses to others. Don't assume that all members of cultural groups share the same beliefs or practices. Participate in ongoing training in the area of cultural competency, cultural humility, and always seek supervision. Always seek supervision. No matter what level you may be in, we always need supervision. So that's a really, really important one I want to hone in on. Actively examine and acknowledge and eliminate prejudice and bias practices. Believe your clients when they share their experiences of marginalization. A lot of the times our clients who do experience that, they do oftentimes can struggle with some form of racialized trauma. So we want to be able to validate that and to believe them, to believe their experiences. Openly address stigma, shame, and privilege, and collaborate to create diverse community networks so that we are able to provide resources for our clients. Right, so ask and talk about the different types of privilege that exist between you and your patients. So let's do a short case study. So we have Jennifer, who is a 20-year-old first generation Asian American cisgender female, college student. Oh, sorry, apologize for that typo. College student diagnosed with OSFED, restricting type, generalized anxiety disorder, and borderline personality disorder. And she is being referred by her outpatient therapist. Jennifer comes from an Indian immigrant family and currently lives alone with her parents, lives alone in her parents' apartment in New York City. Parents visit about 1 to 2 a month, and her sister lives abroad. Jennifer restricts and engages in compulsive exercise daily and struggles with body image distress. This is her first time in treatment, and she's very anxious about increasing her eating and gaining weight because she believes her father will reject her if she does, and her mother may become preoccupied with her body and try to moderate her eating. Jennifer generally feels misunderstood by her family, believe they see her as a problem child, and she does not utilize them for emotional support. So I am going to pose the last question for today. What are some of the considerations for Jennifer's care from a multicultural perspective that we want to be thinking of? So Jennifer's coming to us for the first time in treatment. What are some of those things we want to be able to think about as Jennifer is coming in? So I'll give you all 2 minutes to put a couple of answers in the chat. And then either Ashley or Jamie will read those to me.
We have some responses rolling in. Cultural foods cooked by parents when they are visiting, consideration of family dynamics in the client's culture, explore additional support people in her life, have to be mindful of her relationship to her parents and her influence on how she sees herself and what they think of her body image as well. It looks like family values regarding food and weight.
Absolutely. Absolutely. Yes. All right. Well, thank you all so much for that. So just a few more considerations. If we're thinking about engaging her in treatment and what kind of how we're going to set up our program and how we're going to individualize that as much as we can. For Jennifer, we may want to assess during the intake process how important it might be for Jennifer to have a member or members of her team that belongs to the BIPOC community. We know that sometimes this is not always possible. It's not always feasible to do that. And so when it's not possible and feasible to do that, is there an opportunity to seek supervision? Is there an opportunity to consult with someone external if there's no one internally? So that could be one of the things we want to consider. For Jennifer, we want to also explore the intersection of race, culture, family, and the development of the eating disorder. And with Jennifer's permission, we would hope and really be excited to work with her family if she would allow them to participate in treatment. So here at Within, we offer a bunch of things for our family and the families and the loved ones to get involved. So for Jennifer, in Jennifer's particular case, we may want to do family therapy. In addition to family therapy, we may want to do family coaching, which provides an opportunity for the family members to learn how to support and how to work on those communication dynamics and some of the barriers that may come up and impact their ability to support in a way that truly feels supportive. We may want to engage Jennifer's dad, if he's willing, in our males loved one support group. We may want to get the family involved as well in our multi-family culture group. We may want to also have them in the monthly psychoeducation group and the monthly support group as well. So lots of options there that we could engage the family in if she is willing and if they are willing as well. Thinking about Jennifer on the more individual side, we would want to have Jennifer in our BIPOC group. We have various types of body image groups that we have. So we'd want to have Jennifer in one of our body image groups. Because she is still in college, she's a university student, we would want to have her in our university group that we offer. She also struggles with movement, so we may want to help her rebuild her relationship with movement from the ground up, right? And so our movement process and psychoeducation group might be a good place for her to start doing that, where she could examine some of her beliefs, attitude to movement, and we would also want to have her in some of our other type of therapeutic and skills-based groups, so like the CBT, DBT, RODBT, anxiety management group, co-occurring disorder group, and those kinds of things. All right, so these are a few resources. If you want to take a few seconds, just take a screenshot, take a picture from your phone, or whatever devices you're using. These are a couple of resources that you can look into. All right. These are our references for today. And we want to end on a quote from Mahatma Gandhi. The true measure of any society can be found in how it treats its most vulnerable members. This is how I can be reached for anyone who may want to reach out. And at this time, I would open it up to any questions, comments, and feedback.
Beautiful. Thank you, Malika. That was such a great presentation. We did have a couple of questions roll through the chat, and if there's any additional ones, feel free to add them as well. So one of the questions that did come through was, let me pull it up one moment. How does Within identify clients who are members of the BIPOC community?
Great question. Great question. So at this time at Within, we do have questions in our biopsychosocial assessment and questions in our intake assessment that is asking for those pieces. And we're also asking, we have a little blurb there as well that we have that is giving clients the rationale as to why it's important. You know, a lot of us could relate to going to a doctor's office or something, and we have these checkbox questions. And sometimes we don't want to identify, right? And so we do have that option to put other or prefer not to say. So we took a step further to include a little blurb, a little statement, just kind of giving the rationale as to why it's important, which really is to be able to individualize care as much as possible for our clients.
Wonderful, thank you. We had another question as well pop in. How would you recommend a clinician who is interested in starting specific BIPOC care at their facility?
Training. So lots of training, and also seeking out clinicians who are already in that space who might be able to support with some supervision, especially if you're just kind of starting off. But also if you are thinking about niching down, if it's just BIPOC, it might be LGBTQIA+ as well. That's also another marginalized group. So seeking supervision in any of those respective areas, and then finding someone who could also give you some support in those beginning stages.
Perfect, thank you. And I think we have time for one final question. The question is, what does a typical BIPOC agenda look like for you within your group?
I'm wondering if the person meant agenda as in the topics they can provide.
I believe so, yep.
So, you know, we are looking at things like weight stigma. We're looking at things like disparity in access to care and health. We're looking at how their cultural experiences, what that was like for them, and how that sometimes is missed or ignored or not fully incorporated or considered in their treatment, in their care, especially some of those religious practices, and then also practices around food, things that they may or may not be able to have. Sometimes that's coming from spiritual and religious beliefs. And so we take all of those things into consideration. It really is a safe space. It is more of a place to process more than it is a place to learn, right? We're not teaching people. They have their own unique experiences. So it creates a safe space to bring those experiences, have a safe space to be able to talk about those things.
Wonderful, thank you. And it looks like we are at time. I just want to thank everybody for attending our CEU today and for exploring this topic with us. We genuinely appreciate it. And we want to thank Malika as well for sharing her expertise with us. Feel free to keep in touch on our social media pages for any additional CEUs that do come up. And I just want to thank you all for being here today and for sharing this space with us.
Thank you.